All right, so I figured I'd do another little video for you guys on sleep medications. You know, in the hospital, trazodone is a bit of a mainstay, I would say. I think you'd all agree, but it's not the only option, and it's good to know what's out there. It's been a while since I've actually done this live, so I don't know how many I'm going to remember and whether I'm going to screw it up, but let's give it a go. So. Um, let's say at the very beginning tier, right? Echinacea class or whatever, we'd have melatonin, um, tryptophan, um, one of the magnesium, I think magnesium glycinate. Whereas one of the magnesiums is a for diarrhea, the other one is for or constipation rather, and the other one is for sleep. So magnesium glycinate, yes. So magnesium glycinate. You can tell I don't use it much because I wasn't sure about it. Um, and oh, yeah, that's that tier. I mean, also you could include ashwagandha if you have a hippie patient or something. They often tend to like you more if you tell them to take the things that they're already more likely to take, like ashwagandha. Um, okay, so that's like the pre, interventional tier. Somebody has a little bit of trouble sleeping, and they like clean living and staying chemical free. These are all decent options to give those kinds of people. Usually, by the time somebody's talking to a psychiatrist about sleep, they've gone past this, but not all the time. So it's good to know that there's non medication options. Not and by non medication, I mean more than just that um, uh, that it doesn't require a prescription. There's plenty of over the counter sleep aids that are antihistamines, which I would include in the same tier as other prescription antihistamines, and they don't actually have that favorable of a profile. So if you're talking about getting clean sleep, you can't really do better than tryptophan, because what tryptophan is it's an amino acid um, that is the building block for several neurotransmitters, including serotonin. But basically, it gives your brain the building blocks to make the chemicals necessary to produce sleep. Like sleep isn't a simple phenomenon. There's like a well choreographed dance of chemical soup in your head that goes on to actually create the entire state of sleep and to keep you there. And the chemicals required, many of them, have a tryptophan sort of precursor backbone. And so you take a bunch of tryptophan, it makes you tired. Melatonin technically is a drug because there are melatonin receptors, but your body also makes it endogenously. So, I'm willing to keep this in the non drug class. And then, ashwagandha's, like Ayurvedic herb, and magnesium is, a element. Um, and they all do a pretty good job. So if you want to go further, then of course in the first tier of drugs, let's write down trazodone because boy is that a popular one. But hydroxyzine, Vistaril or Atarax gets used. And in case anybody really wants to know, Vistaril is hydroxyzine pamoate, and Atarax is hydroxyzine HCl. And it basically Vistaril requires bigger numbers because the pamoate is is a complicated set of carbons versus just the HCl. So Atarax 10 milligrams or hydroxyzine HCl 10 milligrams is roughly equivalent probably to Vistaril or hydroxyzine panoate 50. But I mean, nobody splits hairs there, and hydroxyzine is such a kind of throwaway med usually. Anyways, you're probably not putting a lot of thought into the type of hydroxyzine you're ordering. But and hydroxyzine is very much an antihistamine. And so in this tier, I would include all of the over-the-counter antihistamines, including Benadryl. So antihistamine. So like Benadryl, or diphenhydramine, which is the actual name for Benadryl, and ZzzQuil. They have a couple of other antihistamines that they market, but most things that in the pharmacy call themselves sleep aids and have big flashy colors on the boxes to try and lure you in, most of those are antihistamines. And antihistamines, they do sedate, and they also make you feel calm. But when taken in excess and when taken regularly, they can also produce strange muscular side effects, like bordering on movement disorders. Some people get chorea from them, usually temporary. I don't think that there's a permanent syndrome, but it's definitely a weird side effect to experience. And they also have basically the same correlation with dementia that benzodiazepines have, which is one of the reasons why I always sort of look askance at everyone confidently, telling people, well, you got to stop the Xanax and I'll give you hydroxyzine instead. What you did was you took, an effective medication and gave them a less effective medication with similar, risk profile. But hydroxyzine is probably not addictive, whereas, Xanax is. So there's some benefit there, but you always want to make sure that, well, I can get on my soapbox another day with that. We can just keep on with these meds here. So a step up from that would be the other antidepressant sleep aids. And I say other because trazodone is technically an antidepressant. I often tell the story of trazodone to my patients that haven't had it before, which is that, you may look up on Google and see that it's an antidepressant, and I'm not trying to tell you that you're depressed. It gets used today as a sleep aid. And then I go on to explain that, back in the pre-Prozac days, we were very desperate for antidepressants, and it so happens that the Hamilton D scale, the HAM-D, which is the most often used scale in depression studies, puts a lot of weight on sleep. And so if something improves sleep, it doesn't have to do a whole lot more to show a statistically significant effect on the HAM-D. And you didn't actually have to be that impressive on the HAM-D to get FDA approval for depression, as long as you were very safe. And as we all know, since we use it so much, trazodone is safe. It's very safe. It's actually FDA approved up to 600, and I have given a patient 900 before. Unique situation. But the vast majority of people these days are taking it just for sleep, and, at 50 or 100 or 150 milligrams a night. In the original studies, they weren't able to show statistical significance for depression until 300, and there was the most breakaway from placebo at 600. And those people were sleeping a lot. probably too much, which is why it's sort of not a very good antidepressant, but a pretty reliable sleep aid. One thing to know about trazodone is about 15% of people um, uh, uh, conjugate slash metabolize trazodone into an anxiety causing chemical. So if you ever give somebody trazodone and they come back to you and say, it made me drowsy, but like my heart was pounding and I felt terrible and I didn't actually get any sleep. And like, I absolutely hate the feeling of it and I will not take it anymore. Believe them, because there are 15% of people out there who metabolize it wrong. It doesn't, I know the mantra in general is no med works for everyone, but literally this med is like the anti of itself in 15% of people. So usually trazodone makes people feel very calm and a little drowsy, and the calmness and the drowsy together helps with sleep. But in 15% of people, it actually causes anxiety with the drowsiness and just kind of an awful feeling where you're tired but too anxious to sleep. That's no good. So just be aware of that. So going to the non-trazodone antidepressant sleep aids. Oh, that's a lot. I've seen Elavil used. Elavil is amitriptyline. I'm sorry, I'm using trade names of ancient chemicals. I probably shouldn't do that. Let's just write amitriptyline. I'm just scared of spelling the damn thing. But I don't know. Okay, I'm probably already wrong. But amitriptyline is one. The other tricyclics sometimes get used, but you want to know that the tertiary amine TCAs are the ones that are actually sedating. So that's like amitriptyline and desipramine. Desipramine. And also doxepin. Whereas imipramine and nortriptyline, well, I've seen them given to people as sleep aids, I think, and I always thought it was silly and I wanted to take it off. But if the patient says they're doing well, you don't change it. That's, sort of the, um, the primary rule in psychiatry. Um, the prime directive, if you will. But yeah, secondary amines are supposed to be activating. If you want to learn more about TCAs, we don't use them much, but there's some very cool things to learn. The tertiary amines become secondary amines overnight by your liver's metabolism. So amitriptyline becomes nortriptyline, and desipramine becomes imipramine. So in theory, that you take them at night, they help you go to sleep, and then by the time you wake up, they've turned to a chemical that should theoretically help you wake up. Though, of course, there are people who go to sleep on Adderall. There are people who, go to sleep on Wellbutrin. So sometimes wakefulness aids don't actually cause wakefulness. Everything has to be complicated. So I think that's why those people were able to get away with the nortriptyline as a sleep aid. But these are the 3 TCAs that usually get used as sleep aid. One thing it's helpful to know is that doxepin is actually the cleanest antihistamine. It's the cleanest, strongest antihistamine that has ever been studied, I believe, or at least that's safe in human trials. And the reason why that's worth knowing, if it, assuming it is worth knowing, is that it's one of the few psych meds that gets used in dermatology. So every now and then, you got a patient with complex rashes or one of these nervous Nellies that has to see a psychiatrist and a dermatologist twice a week. Those kinds of people exist, and they might end up in your roster as an outpatient someday. Um, it's you definitely want to be careful that people who are like dermatologist shopping might randomly get put on doxepin, which is a TCA, and TCAs have lots of interactions with other psych meds, and you could be throwing somebody towards serotonin syndrome or QT prolongation or whatever it would be because you didn't know about the doxepin. So doxepin is not just ours. Just like amitriptyline and nortriptyline get used by neuro for headache a lot, um, doxepin gets used by derm a lot. So these guys are all about the same level. I kind of forget the dosing for desipramine, amitriptyline. 10 to 50 is what I usually see. Doxepin, it's actually got the FDA approval at the 3 milligram and the 6 milligram, but those always cost more for some reason. So to get insurance to cover it, you give the 10 milligram. Life sucks like that. Anyways, moving beyond those guys, then we're probably going to be talking about some of the novel class sleep aids. So there's two main types of those. So super melatonins and orexin inhibitors. So super melatonins, Ramelteon, Tasimelteon, and there are a couple other Elteons or Melteons. I remember the MEL, means melatonin. And orexin inhibitors, you have Balsamra, which is the generic is Suvorexant. Well, it's not on generic yet, I don't think, but the chemical name is Suvorexant. And then I think Dayvigo, which I think is Dorito Rexant. And there's some other Rexants too. I think that they're all still on brand, which basically means that they're almost out of reach for most people. The thing about these classes is, I put them after the TCAs because the TCAs are just kind of just easier to get. But if we were talking about which one is more likely to cause sleep, the TCAs are actually probably more likely to cause sleep too. These guys are kind of weak, so you might actually, they might have existed, up here on this scale rather than where I put them. If I'm trying to list from the lightest chemical intervention to the heaviest, TCAs, I mean, it's really a jump ball, but you could definitely say that there's some wiggle room, between all of this. Whereas there wouldn't be any wiggle room going down to the next step, which is the antipsychotic sleepers. So the most obvious one is Seroquel or quetiapine. I've also had I worked for 3 or 4 years for an HMO that had this one PCP that put all of his patients that couldn't sleep on Zyprexa, which, I mean, it's chemically close to Seroquel, And it honestly does help with sleep, especially for non-psychotic people. I mean, it's a sedative, and in general, like the first name for the class of medications that we now call antipsychotics was heavy sedatives. When Haldol first came out, Haldol and Thorazine were called heavy sedatives. It took a while for the term antipsychotic to catch on. So these things, all of these molecules are sedating. But Seroquel gets used a lot. Zyprexa gets used a little bit. Um, but yeah, so that would be that tier. And then going up a tier, then we have the sort of Z drugs, which are also more correctly called the PAMs. And then the benzo sleepers. So the Z drugs is Ambien, which is Zolpidem, Lunesta, or Esoplicone, and Sonata, or Zaloplam. So PAM stands for positive allosteric modifier. So in one of my other videos, we were talking. Oh wait, it might have been this video. Let me scroll up. No, it wasn't this video. One of my other videos, we were talking about how receptors have different regions, and there's the binding region and the non-binding region. Basically, positive allosteric modifier means that you change the shape of the protein in a way that modifies its activity in a positive manner. Positive allosteric modifier. So basically, you're not connecting to there. That's like if, and for the record, we're talking about the GABA A receptor. So I should just write that here, GABA A. So on the GABA A receptor, benzos go there, and Z drugs would go to this region, somewhere in the non-binding region. And so what Z drugs do is they bind around here, and it changes the conformation of the receptor to allow your endogenous GABA, just the GABA that's in your brain, to lead to more bang for your buck, more downstream effect from the GABA. Whereas the benzo sleepers just directly mimic GABA and give you the extra effect that way by just mimicking the GABA. That being said, that's why it's not exactly favorable to use both, because if you're changing the conformation of the receptor to be more reactive to a ligand, and then also providing extra ligand, you can get to a point of sedation that might not be super duper safe. Now, to just list some benzo sleepers, the one that has the FDA approval, or I think that there's a few, but the one that is the most relevant is Restoril or Temazepam. Restoril, that's an R. / Temazepam, TEMA, Temazepam. I think that what is it? Triazolam also has the FDA approval, if I'm not mistaken. And so I think that there are a few benzo sleepers. Now, that's not to say Xanax gets used for sleep. Ativan gets used for sleep. Klonopin, Valium, there are people getting it off-label for sleep. But I figured, in this list, I can leave those out because we're talking mostly about on-label use. Except, of course, these antipsychotics aren't on it, but whatever. Foolish consistencies are hobgoblins. So then moving beyond this, so if you have somebody that has such severe insomnia that they've tried the thing, like you've been starting on the lower tiers and amping up, and they're just still miserable, not getting sleep, and you really trust them that they're not like just drug seeking and stuff. And you got to be careful because this, if you're gonna be somebody that treats sleep, you got to also have your guard up for people that are just like shopping for sedative. But you know, you got good rapport with somebody, you trust them. The next step up, it starts to get pretty grim. So, and I really try to never go above this. So I usually put a dotted line here and say, don't go past the dotted line. I'm just kind of giving you extra information for no reason. But Haldol does get used for, for refractory insomnia, often in conjunction with one of the older higher tier drugs, so like maybe Ambien and Haldol in somebody with like just severe insomnia. You could also make a case for trying a little bit of a benzo with Ambien in super severe cases, but good luck trying to get a pharmacist to fill that these days. But yeah, Haldol gets used, and I never want to give anybody Haldol that's not psychotic if I can avoid it, right? Like the side effect profile sucks, and it's just you're not winning the battle when you're using Haldol for sleep. And then beyond Haldol, we need a whole other new line, maybe like a couple of dotted lines, because you really shouldn't be going past this. But they do have what is it? Oh damn it! I have to look this up. So okay, I just remembered it while I was trying to look it up. Oxybate. There's two types on the market. There's the standard sodium oxybate, and then there's the sodium and potassium oxybate for people. And I think they also include magnesium oxybate. It's like oxybate salts that try and spread it away from just sodium because it does end up being quite a bolus of actual sodium to your system. But yeah, so Na2 plus oxybate. Now, this is or one along with Rohypnol is one of the main date rape drugs that get used. Evil people use it to abuse people, and so it's only dispensed from a single pharmacy in the United States. You have to register your patient in a federal REMS program. A lot of municipalities require you to tell the police department and the fire department, and that's not because necessarily you're getting access to the date rape drug, though of course I'm sure that the cops do take notice. But it's also because you won't be able to wake yourself in an emergency. So you got to tell the fire department so that they know in the event of a fire, you're going to literally need a fireman to go into your bedroom, pick up your sleeping body, and pull you to safety while you're sleeping through a very loud, crazy fire. These things produce sleep, in a very on and off, matter of fact kind of way. They do tell you to wear diapers, and most people become at least slightly incontinent to urine, and some people even to feces from how deep the sleep is. Um, uh, it has to be taken twice a night because it usually only provides about 3 to 4 hours of sleep. Um, so they have you take they usually give it to you in liquids, and so it's similar to methadone dispensing in that way. They mail you these little cups, and you drink one cup and lay down, and then when you wake up, you drink the next cup, which you're supposed to keep next to your bed, and lay back down. And you never have to worry about peeing during the night again because you're just doing it in your diaper. But yeah, so this is what I would call bad news bears, and let's just not ever go there. But I'm including it for completeness sake. So we went from everything from melatonin and tryptophan all the way down to sodium oxybate, and I'm hoping that I didn't miss anything super duper obvious. Um, but every time that I write out this big long list, de novo, I end up coming back to it, hours later and being like, oh, what the hell? I forgot that really obvious one. So if I did that, my apologies. But anyways, I want you guys to know that I appreciate everything you do, and nurse practitioners keep the hospital running, and stay awesome and go team.